Test 1, 2, check, 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 test, test, test. Test 1, 2, check 1, 2, test, test. Test, 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 1, 2.
here is on. Yeah, yeah. Well, I won't if there's 3 bars. Because I have it of it. Yeah. There we go. Good. Tap it, yeah. That's now ready to go, but I'll mute it. There.
Good morning, everybody. Welcome to Grand Rounds. I think we're going to get started. Thank you for coming on time. This morning's Grand Rounds is brought to us by the Division of Gastroenterology. Can you hear me? No? Can you hear me now? No? Can you hear me now? Yeah. All right. This morning's Grand Rounds is by the Division of Gastroenterology, and there's 3 speakers. Dr. Hin Ko, Dr. Enns, and Dr. O. And I think Dr. O is going to lead off. So, Dr. O.
All right, hello everybody, and I see that we still have people coming into the room. So hello everyone. My name is George O. For those who I haven't had the pleasure of working with or meeting in the past, I'm one of the gastroenterologists here at St. Paul's, and the topic that we're going to be covering today is kind of a topic that's really been garnering a lot of attention in the recent years, particularly in the class of medication that we use very commonly in a lot of our patient population. So here we're just discuss the complications of a PPI and trying to clarify whether some of the things that we've been seeing in the literature in recent years are in fact truth facts or are they mere fictions. So just start off with the disclosures. And so the objective of the talk today is really to understand the risks and the benefits of using PPI both short-term and long-term basis, and to understand how we can apply these information into clinical practice to identify which patients long-term use may be appropriate and others perhaps not so much. So to start off with just a very obligatory short history, the PPIs were first introduced back in the 80s, and it is currently one of the most commonly utilized medications both in inpatients as well as in outpatients. The reason that it has really taken up in the past few years is because multiple studies have repeatedly demonstrated its superior efficacy in terms of managing a myriad of GI conditions compared to the older generation class of medications, the H2 receptor antagonists or receptor blockers. So currently, a number of approved indications for PPI include GERD management, erosive esophagitis, peptic ulcers, H. pylori treatment, and it's also being used increasingly for bleeding prophylaxis and those requiring long-term NSAIDs or aspirin or other anticoagulant use. So with its increasing use in our patients, then a lot of questions are becoming more apparent in terms of, well, if this medication is really good, what are the downsides? You know, as you know, most of the things that we do in medicine is a bit of weighing benefit versus the risks. And in this case, there has been a lot of proposed potential adverse effects of PPI, basically from head to toe, if you will. And some of the more commonly talked about complications include C. diff, diarrhea, other enteric infections, fractures, pneumonia, and more recently dementia, and also its effect on the cardiovascular system and also on kidney disease as well. So to understand where all the recent alarms are coming from, I think it's important that we understand how the studies have really come about looking at the potential problems with usage of such widespread use of PPIs. So it's important for us to go back and look at some of these various study types and really understand their strengths and weaknesses. So first off, a lot of the studies that have really examined the effect of PPIs looking for their adverse effects have really been primarily retrospective cohort studies. There's also larger observational studies that have utilized administrative data using the diagnostic codes, using insurance databases in parts of the world where it's more readily available. And along with that, there's probably just as many, if not more, meta-analyses that have been done on these studies looking at the potential side effects. To date, there are actually very, very few in comparison in terms of randomized, good quality control studies that have been designed to address the specific question of are PPIs causing harm for our patients. So that's something to keep in mind moving forward as we look at the data that's available to date. So as you know, a very important question that we need to ask ourselves when we're trying to establish causation is that there are certain criteria that should be met, and these are fairly logical criteria. So here is the Hills criteria that was proposed a couple decades ago, and a few criteria to note here is really the strength of the association, the biological plausibility, and biological gradient or a dose response. And so these are kind of really big topics I would encourage all of you to think about as we go through some of these studies looking at the different side effects. To start off with the strength of the association. So basically that's what's saying is the magnitude of the effect. Is it really significant enough for us to really believe that it exists? Now, a classical example would be kind of smoking and lung cancer. As you know, in those, there's never really been randomized control studies to show that, yes, smoking caused lung cancer. But because the magnitude of the association is so big and because all the other observational studies have been very convincing, and therefore we have accepted that as true. But for the PPIs, all of the side effects that has been brought to light in recent years, they really kind of have very low magnitudes with odds ratios that's mostly in the between 1s to 2s, occasionally 2 to 3s. So in the grand scheme of things, they're not all that impressive. So that's the first thing to think about. An association does not equal causality, as many of you know. In the absence of a very good controlled randomized placebo-controlled trials, any association that we see merely reflects association. There still remains a lot of questions to be answered to try to explain the association that's been observed. And part of the biggest issue with all retrospective and cohort studies that we have seen to date is confounding by indication. And really the best way to address this would be to design a very well-designed randomized control trials. In all the others, there can be a ton of fancy statistics that can be put in place to try to control for these, but unfortunately, there always remains the question of residual confounding that perhaps the study just did not account for. And along with that is the concern of channeling bias. And this is basically a scenario where physicians, as clinicians, there may be a tendency of prescribing certain medications based on the frailty or the comorbidities that a patient may carry. And so this figure here nicely lays out that, you know, the PPI use does tend to be more prevalent among patients with multiple comorbidities, be it diabetes, be it cardiovascular disease, be it a malignancy. So really, we're looking at a much greater use of the PPIs and those with a larger number of underlying comorbidities. So next, we're going to review a little bit of the data and on the various side effects that's been brought to attention. So first off, I thought we'd start out with the PPI-clopidogrel interaction. This really came about in the around the 2010s, and with some studies that have proposed a possible interaction between PPI and the clopidogrel, mainly through the cytochrome P450 system. PPI, in order for it to be metabolized, to be rid of, it relies on the cytochrome 2C19. Now, interestingly, this cytochrome is also the one that's responsible for converting clopidogrel into its prodrug. About 15% of the clopidogrel is actually converted into active metabolites through this pathway. So as you can imagine, in someone taking PPI, there's a theoretical competitive inhibition of the cytochrome P450 such that the clopidogrel, perhaps a less proportion of the actual clopidogrel is metabolized to an active metabolite, thus rendering its effect probably less protective effect in those with the cardiovascular disease. And therefore, FDA Health Canada have come up with advisories recommending that perhaps in patients who are on clopidogrel, that the PPI choice be limited to those with less effect on the cytochrome P450 system. And one such PPI is one that we commonly use in hospital as well as out of hospital would be the pantoprazole. So this trial has probably been beaten to death basically numerous times since this has come out. It's really one of the first studies that has designed a randomized control trial that has designed to address the safety and the efficacy PPIs and dual antiplatelet therapy, comparing basically among patients who all require dual antiplatelet therapy, and then they add the PPI or placebo to those who are taking these. One thing to note is that this study was ended early due to loss of sponsorship, but it still generated some interesting data that we should still continue to consider. For starters, it showed that PPI was actually effective at reducing composite GI outcomes, primarily in the form of GI bleeding. So it does demonstrate that in the setting of a chronic dual antiplatelet therapy use, that the PPI can be protective against GI bleeding. And the other interesting effect I was seeing from this trial was that despite the addition of PPI, despite the theoretical risk of interaction due to the cytochrome P450 system, that there was actually no increased risk of cardiovascular outcome. Now, a common criticism that was brought to this study was the fact that while this study ended short, there were so few cardiovascular events, perhaps the study is really not powered to detect such a difference. So noted, but still, this is keeping in mind the quality of the studies that we talked about before, so that's why this is one of the better data out there. So then subsequently, the same authors who participated in the COGENT trial came out with a systematic review and meta-analysis looking at what we see in vitro, because in vitro studies did demonstrate that PPIs is affecting the metabolism of the clopidogrel, and then they compared that to what we see in actually clinical trials. So I know, sorry, this is a bit very, very hard to read. What they're basically showing here is of all the studies that utilize laboratory studies to assess the efficacy of clopidogrel, basically, yes, it is indeed showing that PPIs does decrease the efficacy of the clopidogrel. But then when they look at all the trials that have implemented clopidogrel with some form of PPI, they were not really seeing much of an effect. And just to read off to the audience here, really the odds ratio that they're seeing here is 1.13. Again, keep in mind the magnitude of the association and the fact that the 95% confidence interval actually crossed 1, which means that there's no significant difference here that we see. So perhaps that could put to rest the question whether PPI does interact with clopidogrel. I think the conclusion from that was, yes, perhaps it does, but maybe that interaction doesn't really translate into the clinical outcomes. So as another effort to look at the interaction between clopidogrel and PPI was people kind of went back and looking into the larger cardiology trials to see if they could tease out doing some post hoc analysis. And one such study was the analysis of the PLATO trial, where they were comparing clopidogrel with ticagrelor, and they went back and looked at the PPI use to try to see if there is indeed any effect of the PPI use on cardiovascular outcome. And what I would like to point to here, again, I know my apologies for the small font here, what they're basically showing is PPI versus no PPI. Across both classes of antiplatelets, there is actually increased risk of cardiovascular event. So that brings up a question, well, if we think that PPI was inducing increased cardiovascular events through the interaction with clopidogrel, in theory, you really shouldn't be seeing that in the ticagrelor group. So then this led to a lot of other theories that perhaps the PPI itself is an independent risk factor for cardiovascular disease. And so over the last decade or so, there has been a lot of observational cohort studies, again, a lot of systematic review meta-analyses on these specific cohort studies that have shown perhaps that there is an association of PPI use that is associated with increased cardiovascular outcome independent of the antiplatelet use. But what I thought was interesting was that even in the PLATO trial, when they did the post-hoc analysis, the authors were actually very cautious in terms of over-interpreting the results, namely because of the confounding that they could not possibly control for. Remember, this trial was randomized between clopidogrel versus ticagrelor, not the PPIs. So again, it does not address the confounding by indication. Now, what's the biological plausibility for this independent risk factor? In vitro studies have shown that perhaps through this cascade that the PPI can somehow decrease the activity of nitric oxide and therefore leading to increased cardiovascular events. So at least there is some plausibility in terms of biological mechanism. Now, since that time, a few more meta-analyses have come out, and this time the meta-analyses have really focused on randomized controlled trials. Now, instead of focusing on cardiovascular trials, this group of authors actually went back and looked at all the gastroenterology trials, the trials where the PPIs were actually being randomized, looking at various indications such as GERD, esophagitis, and in trials where cardiovascular outcome was one of the outcomes that was measured. And what they found in these randomized control trials, when they collectively analyzed the results together, was that they showed no difference, indicating that the PPIs themselves are not really an independent risk factor. And what they thought was interesting was they went back and looked at all the observational studies again as well. And indeed, they're still seeing the same thing that all the authors before them have seen, was that there was indeed an association. So this really highlights the fact that a systematic review meta-analysis is really only as good as the trials that's being incorporated into the studies, and that in this case there's a clear differentiation between what we can see through the randomized control studies versus those that are just observational, where confounding is not controlled. And another group of authors did another meta-analysis, and this time they looked at randomized control trials using cardiology trials, and here they're again seeing no real difference in terms of cardiovascular outcomes based on the PPI. Now, in the past year, there's been a new publication of the trial. This is a randomized control trial that looked at patients taking antiplatelet therapy, anticoagulation with rivaroxaban, and also randomizing the patients to PPI versus no PPI. And what this study showed, and sorry, my slide is actually not showing up. Sorry, there was actually supposed to be a figures. In fact, the figure shows that when they analyzed the patients based on PPI use versus no PPI use, there was actually no difference in the cardiovascular outcome. And just keeping in mind that this is actually one of the more updated randomized control trials to date that specifically address cardiovascular outcomes in patients taking PPIs. So of the standard of the qualities, this is probably perhaps at the top at the current moment. So conclusions that I alluded to earlier is that perhaps, yes, indeed, there is an interaction between PPI and Plavix and clopidogrel. Then really, this interaction does not seem to be translating into clinical outcomes. So perhaps we should make a note of that and utilize the PPIs that are known to have less interaction, such as pantoprazole. And the take-home message from here as well is that the results from the COGENT trial is true, that PPIs do protect against bleeding events, and therefore, considering weighing the benefit versus the potential risks, in this case, it's pretty clear that PPI would be beneficial in the long run. So next, I wanted to talk to you a little bit about the PPI's effect on the kidneys. Now, a commonly cited adverse effect of the PPIs is acute interstitial nephritis. This has been seen repeatedly in both case reports, case series, observational studies, and with a fairly perhaps convincing causality in that oftentimes a rechallenge will lead to recurrence, which is kind of a mandatory requirement for drug-induced injury of any sort. And what's interesting to note here, however, is that there is actually, it's not a dose-response phenomenon. So it's not like a patient, if you're on BID dosing, if they're taking PPI for more than a year, that they increase the risk of acute interstitial nephritis. This it could happen anytime, anywhere, and the thought is that it's because it's an immune-mediated response. Now, more recently, there has been more attention paid to, well, what about chronic kidney disease? We know that acute AIN is there, but then what about patients with chronic kidney disease? There's been a few large observational cohort studies, a lot of them based on administrative data, again using insurance coding to try to study the effect of patients on long-term PPI and chronic kidney disease. And when they pulled all the studies together, what they have found is that, yes, perhaps there is a slightly increased risk of chronic kidney disease among users of PPIs, with a hazard ratio here of 1.47 with the lower bounds of 1.03. So really the magnitude here is really not a lot. And you can see on this forest plot is that most of them really lie very close to the line. And what I would like to bring to your attention is this is another systematic review meta-analysis published around the same time, designed to answer the same question. They end up incorporating different studies, slight differences in the studies that they included, but they came to similar conclusion. Again, these are mostly observational studies. And most of the patients are actually driven by one trial that look at the VA system in the U.S. And as far as I can tell, the same authors actually published the same article in another journal utilizing the same, what looks like the same cohort of patients, except they have a different number of subjects. So the validity is a little bit suspicious in my mind. So in terms of when we talk about biological plausibility, we kind of have talked a little bit about that for AIN. We talked about that for cardiovascular disease. But for CKD, we don't really know. We don't really know what's the underlying mechanism. Some have proposed that perhaps it's due to repeated acute interstitial nephritis that these patients eventually end up with chronic kidney disease. But based on the previous observational studies, they can actually develop CKD independent of having an AIN. Some people have proposed that perhaps it's the gut flora. As you know, microbiome is really booming in recent years. There's a lot of hypothesis that perhaps the gut flora is related to a lot of chronic conditions that we face. So perhaps that is one mechanism. Other proposed mechanisms include perhaps these patients are just chronically low in magnesium, which can accelerate renal injury leading to chronic kidney disease. Perhaps there is a direct effect of the PPI on endothelial function, for example, such as the nitric oxide effect that we had talked about earlier. So, but none of these have actually been proven. These are actually brought up and discussed, but we really don't know. The only thing that has really been supporting the PPI association in CKD so far is really possible dose response, and that was in one of the earlier trials where they know that there is an increased incidence of chronic kidney disease when in patients who are taking BID dosing and PPI compared to those who are taking daily dosing. But when we look at the difference in the magnitude, it's really, really minuscule. So I'll move on to the next topic by Dr. Enns.
So hopefully the principles that Dr. Howe's laid out, you recognize will go through every study as we go along through these different disorders, because those principles apply to pretty well everything from here on in. He's actually presented the best studies that have been done, and once you get into these meta-analysis and probably better termed systematic reviews, because studies are quite heterogeneous and can't be combined well, you'll see the same results over and over again. And so the principles that he's laid out, we want to continue to apply. The one I'm going to talk about firstly will be C. diff-associated diarrhea. Now, you also see that the last number of years there isn't as much excitement about PPIs. A lot of it's kind of died out for many reasons. Part of it may be that everyone that was listed at the beginning all have genericized. So we now have generics. They're much cheaper. The impetus to perhaps limit their use as far as cost has gone down. However, the principles still apply to use the lowest dose that patients require is a general principle, I think, for all of our patients, for all of medications. So to be used appropriately at the lowest dose will carry through whether the medication is free or not makes no difference, because all medications potentially have some side effects. So to go through with C. diff, this was, again, 2012. Health Canada, possible risk of C. diff-associated diarrhea. FDA put out that there may be an associated risk with C. diff-associated diarrhea. And recall that there certainly are outbreaks of C. diff that have occurred in Canada. We typically have outbreaks, at least in many sites, where antibiotics are simply used and patients do well, but certain outbreaks have resulted in significant, not only morbidity, but significant mortality, depending on the type of C. diff. So, is there biologic plausibility? First question. Well, we know that C. diff breaks out and patients may be on PPIs or not on PPIs, but is it likely that perhaps if you decrease acid in the stomach, perhaps the spores from the C. diff are more likely to survive the stomach on their transit route to affect the colon? However, we know in C. diff outbreaks that the whole ward gets affected, multiple patients get affected, some on PPIs, some not on PPIs, and many of them seem to have normal acid. And we know that C. diff breaks out commonly in patients with normal acid in their stomach. So this is interesting thought process. Maybe PPIs might alter the gut microbiome. Very trendy to talk about the microbiome and SIBO, etc. But could this potentially promote C. diff-associated diarrhea? When we look at risk factors in the community out of Quebec, and recall that Quebec has had serious outbreaks with C. diff with significant mortality. There's a case control study of Quebec admissions using administrative database, over 800 cases. And this is just to put it into perspective. Because when you look at some of the risk factors, obviously antibiotics are number 1, 2, 3, 4, 5, 6, 7, 8, 9, and 10 on your list. The antibiotics are way at the top. Then we get into other things like IBD, and this is well recognized in the inflammatory bowel disease population. Then you get into, in fact, IBS, people with irritable bowel syndrome. Then you can discuss renal failure, and PPI use is coming in at the bottom of this list. Now, the list is actually much longer than this. I just put it in there for perspective, just to keep it in mind. So that hopefully puts in perspective a little bit. What is the evidence? If we look at the evidence, again, combined systematic reviews and meta-analysis, now this is throwing apples and oranges together and trying to come out with some type of conclusion. I'll show you on the next slide. Another investigator wouldn't do that. He just picked the studies he felt were most appropriate. Odds ratio 1.65. Again, odds ratios that are less than 2 aren't really exciting in general. High risk of bias, publication bias. The quality of the evidence is very low. The number needed to harm for hospitalized patients over 14 days, you had to treat 50 patients if they were on antibiotics with a PPI. If they were not on antibiotics with PPI, you'd have to treat 367 patients to come up with one patient that would be affected by this if the odds ratio of 1.65 was true. In the general population, if you're outside a hospital, the number needed to harm was up in the thousands. Obviously, this risk factor odds ratio in an outpatient population doesn't amount to very much. In an inpatient population, it's more interesting, and perhaps a little more interesting in patients on antibiotics. But the odds ratios, the number needed to treat normally we think of is really probably closer to 1/10 of what we're looking at here. So the magnitude of effect is very small in this setting. Gregorius is from the author of this study, who is I guess his mentor would have been the first author of the COMPASS study, which George presented. Gregorius is at McMaster, and he is a methodologist with no disclosures. He does not do any industry or, as far as I know, government work. So he has spent his career making sure that he has no disclosures. He's a pure methodologist. And so as a pure methodologist, he can only pick out studies that he feels are reasonable to put together. So this was looking at the risk of CDAD in 2013. He looked at the most recent studies, and he did emphasize the one study that had a low risk of bias. The only study that had a low risk of bias, in fact, showed no effect at all. If you lump the 4 observational studies together, there was, again, your odds ratio 1.79. but overlapping with 0.98 to 3.27. Quality of the evidence was categorized as low, and really the motherhood statements of use a PPI if appropriate, focus on the higher risk issues. And these statements are going to come up over and over again. If it's appropriate to use it. If it's not appropriate to use, don't use it, obviously. So that's kind of the C. diff approach, that in general, if there's an effect, it's so small that it likely is negligible, and you should focus on higher risk issues. So we've done 3 areas thus far, and now we'll focus on the 4th, which is pneumonia, the risk of community-acquired pneumonia. We know that there's, at least in some databases back in 2008, increased risk of community-acquired pneumonia in primary care databases. Remember that these databases are not designed to look specifically at PPIs, but they found that those patients that were on PPIs had a 1.89 relative risk increase of developing and community-acquired pneumonia. What was interesting is that the longer you were on the therapy, the less likely, in fact, you were to develop pneumonia. Your risk went down with time. Now that is not logical, and so this whole issue of biologic plausibility raises its head once more. Is it logical that the longer you take a PPI, the less likely you'll get pneumonia? The thought process right away should go, well, maybe when the patient presented with a cough, they were given a PPI because the physician thought that their cough was related to reflux, and it turned out to be pneumonia. These are the types of confounders that are very difficult to tease out of databases because the database is there, and it only gives you the information that has inputted into it. So likewise, when this was looked at in a UK GP research database, the relative risk was only there if the patient had been on the PPI for less than 30 days. And what was even more interesting is when you broke the 30 days down to 2 days, it was extremely high. So this really doesn't make any sense at all that somebody on a PPI for 2 days, which the PPI has not even reached full effect in most patients, it makes no sense that this would lead to pneumonia. And so for these reasons, for the most part, this thought process has been let go. Another study from 2010, the data concerning a possible association between PPI and the risk of community-acquired pneumonia are conflicting, and the whole issue of shorter periods with an increased risk doesn't make sense. In this study, they looked as a meta-analysis, again, lumping together 6 other studies. A small association, odds ratio even lower than we've discussed previously at 1.36 was found. It doesn't overlap with 1, but an odds ratio of 1.12 to 1.65 is usually not considered significant. Next one. PPIs and pneumonia, the bottom line, poor long-term association which lacks biological plausibility. The strong short-term association certainly suggests confounding by indication. And the evidence of this causal relationship, I think, remains inconclusive, but even if there is a small risk, it is so small that other areas should be focused on. Meta-analysis of prospective controlled trials essentially found no increase in risk. I'm going to hand it over to Dr. Ko, who will take over the last couple of complication issues and then come to some conclusions and wrap up. Thank you.
So you probably see a common theme now about all the type of studies included. So I'm going to talk about the PPI and osteoporosis and the fracture risk, which honestly in a week I think at least asked a few times by my patients like, oh, I don't want to take the PPI because I worry about osteoporosis. So going back in time a little bit, this is done 13 years ago, but published in JAMA, the journal. So basically, they find this case control with hip fractures, and then they look at the usage of PPI. So these are number. They basically then find another control group, again, but those are the one not using PPI, and then basically see the higher risk of hip fractures for those patients on PPI. So look at the graph on the left side, basically saying looking at the risk of hip fracture at just odd ratio. So you can see the longer duration seem to link to the increased risk of hip fracture. And on the graph on the right side, basically related to the daily dose. So if you take more than 1.75, seems to be, again, higher dose, maybe linked to higher risk of a hip fracture. But there's a lot of limitation to this study. So first of all, they really just try to match the gender, the age, but there's a lot of comorbidity they're not able to match, basically just NAS control. So you can see it's not a great study. There's some signals that are leading to people talk about, oh, maybe PPI will increase the risk of fracture osteoporosis. So moving forward a little bit, so these two studies are published in 2008 and 2010. So the first study is a Canadian study basically looking at, say, drugs that inhibit gastric acid for long duration of time, over 7 years. They just say might increase the risk of risk fracture after they look at all the big number of patients. And then one in 2010 basically look at these number, 33,000 of patients diagnosed with hip fractures. They match it again, we match the controls without hip fractures. So they say maybe patients with hip fracture are at greater risk of taking a PPI. So odds ratio, again, very low, 1.3. Even H2 antagonists, 1.18, the odds ratios. So they say higher dose seem to increase risk, but really they could not demonstrate there's any duration response effect. So if you remember the Hughes criteria, you were supposed to meet all of them to make a strong associations. And they said the excess fracture is only present when among patients with at least known risk factor. So, you know, probably it's probably the underlying risk factor rather than the PPI itself. So is it real? So based on what we know so far, so all data demonstrate PPI and hip fracture association, they're all coming from observational trials. So they're not the greatest design trials. And because of this, we cannot say it caused the hip fracture, so cannot prove causality. And also keep that in mind, just like any other complications, there's always bias from residual confounding factors. You cannot control and measure variables, and it's very hard to, many confounders, many risk factors are osteoporosis. You have to tease it out completely before you can say this is due to PPI. So what leads to this? Is it biological plausible? So hypothesis is that PPI use, you reduce the gastric acid level. So because of this, they say you decrease calcium absorption leading to osteoporosis and then subsequently increased risk of fracture. But there's some two randomized control studies that basically say if you take calcium with food, actually PPI won't affect the calcium absorption. So really easy to solve problem. And there's one randomized control trial, 9 observational studies basically say PPI doesn't cause or worsen osteoporosis. So remember the Hughes criteria, we want to look at the biological gradients. So you know the plausibility maybe, so is it any dose and duration response? So looking from all the study from 2006 up to 2012, you can see a lot of inconsistency. Some studies say there might be dose response, some say not, and duration response the same. They see a mixture of yes and no. So basically you're lacking of consistent dose or duration response. So again, doesn't quite fit the Hughes criteria. So this is like the more recent one, 2013 and 2014, the systematic review and meta-analysis. So again, you just look at the case control study. So not a great study, odds ratio is only 1.21. A little bit better study design, cohort study. Again, odds ratio is still really low, just only 1.3. So again, very heterogeneous study, quality of evidence is very low. So number needed to harm, even assume this is the risk given this odds ratio, you have to treat like 2,000 of the 50-year-old Canadian. Remember when you're older, increased risk of the osteoporosis, lack of sunlight, or in Canada probably will contribute to osteoporosis. So you have to treat them for a whole year, treat 2,000, maybe you find one case. So again, even assume it's true, the risk is very, very low. So leading to health, what do Health Canada and FDA say? They're like politicians, they're always sitting on the fence, right? So basically say potential risk of bone fractures, Health Canada says, and FDA say, yeah, possible. Again, very same conclusion as the other complications. So what did Canadian Association of Gastroenterology position statement say? Basically, we said there's little to support the hypothesis that the association between PPI and risk of fracture is causal. And even we assume this is a cause, the absolute risk is very minimal. So what I tell my patients, I would say, yeah, if they have high risk factor, I screen them. I do bone density scan because, you know, some like the elderly female, they don't have enough calcium intake, so I do the same thing anyways. And also just like medication, I want to try to minimize the use. So moving on, another very concerning thing when it first came out is about PPI and dementia. Just like in medicine, you know, we try to blame it on something. And then we see a lot of people, I see a lot of fatty liver patients or liver disease patients, they always say, oh, I have the right-sided abdominal pain. They think must be the liver. They want to blame it on something. So similarly, dementia, we really want to say must be one reason. So again, PPI being blamed on may be linked to dementia. So is there any biological possibility? So one possible mechanism, they said PPI might affect amyloid beta metabolism. And they said this is one of the pathological markers of Alzheimer's disease, but it's only one of the pathological markers. So possibly, is it possible that PPI crossed the blood-brain barrier, then enhance this amyloid beta level in the brain, and then decrease the degradation, maybe then subsequently linked to increased risk of the dementia? So the another proposed theory is that maybe because of decreased acidity in the stomach, it leads to vitamin B12 deficiency. So keep that in mind. There are many things, when we look at the cohort, there are many other risk factors, age and other things that can increase the risk of dementia, not just PPI itself. And you can see all the cohort, you know, PPI widely used in the older population, so they are already at risk of dementia. So again, cannot really prove this is the medication causing the dementia. So I did find a systematic meta-analysis and systematic review, but again, really depends on how good the data you put in it. I would say it's not good. There's only 6 cohort studies, huge heterogeneity. The length of follow-up from less than half a year, about half a year to 9 years. Size of the cohort, about 150 patients to 73,000 patients. And in terms of definition of PPI, it's really variable. Again, sometimes it's a self-reported based on records. So again, it's not good to start with when you put in this meta-analysis. But as you can see, among the 6 studies, there's 4 of them show positive association between PPI use and risk of dementia. But you can see the risk ratio is really wide range, crossing 1.78 to 2.85. And you pull them together, again, it's only 1.23, and definitely not statistically significant. P-value is 0.19. So when you look at the 4 positive study, so compared to non-PPI use, the risk of Alzheimer's caused by PPI, again, wasn't significant. So again, we don't have a really good, strong or good data to prove PPI linked to increased risk of dementia. So in conclusions, all we can say is there's a lot of heterogeneous study among different studies. So the population is different, PPI exposure is so variable, and there's no adjustment of confounding factors. So bring it back to the COMPASS, because this is a new study that published a few months ago. I mean, Dr. O already mentioned about the cardiovascular risk. So basically, they look at the one group, you look at the kind of like the table on the left. So the group on pentoprazole 40 milligram daily versus placebo. Then they look at the incidence of gastric atrophy, C. diff, outer enteric infections, and then calculate the odds ratios. Only the one a little bit close to significant with a p-value of 0.08 is only enteric infection. You look at the other ones, they are like really low risk and definitely not statistically significant. So there may be some signal of increases of enteric infections, but again, if you use this number compared to what's been published previously, risk is lower than the estimate by the systematic review of observational study. Again, with Dr. Enns mentioned, maybe as the secretion is protective, acidic environment to protect it against curing of the infectious organism. But again, the number needed to harm in this analysis is greater than 300 with 3 years of PPI use. So again, even if this is true, the risk is very low. So in conclusions, so all you can see, all the proposed observational studies, there's no strong evidence to prove that PPI caused all the complications we talk about. And there's a lot of confounding factors. There may be some possibility, but due to some of these associations are causal, but we cannot be, I mean, so far, there's no strong evidence to prove it is. I mean, we cannot completely exclude either. So what do we tell our patients? I would say if someone really need it, I would say tell the patients it's very safe to continue, but it should be taken at the lowest effective dose and only as long as they really need it. If they feel better, I will go through the list and ask them, do you really need the PPI? If symptoms are better, I will stop it and only take it again as needed. So we're now open for questions.
My goodness.
It's all very clear, right?
Yeah. Any questions for any of the presenters?
Yeah, hang on.
George. Sure. Yeah. All right.
So, George, you mentioned the use of pantoprazole in the setting of perhaps less interaction with CYP2C19. and which I get from a pharmacological point of view. What I don't quite get is I would just tell them, I would just say there's no interaction, so don't worry about it. You've said that there might be one drug that's better than the other, and those two conflict. If there's no interaction, there's no interaction, don't worry about it. As opposed to picking a drug that has less interaction, but an interaction doesn't exist, so why would you pick a drug that has less interaction?
Yeah, so I think the reason for my saying that is because in vitro studies does demonstrate such interactions. I think that interaction is, we can't refute it, but again, it doesn't really translate into clinical outcome. Now, it's perhaps, you know, that really the way I say that, the reason I say that is really more of a treating the clinician than as opposed to the patient, in a sense. If you want to really be able to clearly explain your rationale for continuing the PPI use, and you want to explain that you're using the safest, perhaps the safest and the lowest dose possible, then that is one possible explanation that you can provide the patients and also potentially the cardiologists or pharmacists who may be very concerned about the potential interactions. That has been very clearly outlined in the in vitro studies. And because we do know that pentobarbital, for example, does tend to have less interaction with clopidogrel, and therefore that would be a natural option to go to. But as you point, one other thing which I didn't really talk about is really the expression of the CYP2C19. As many of you may know, that the expression of that is actually variable, especially particularly in the Asian population where there tends to be a lower amount of fat cytochrome in activating the clopidogrel use anyway. So in fact, we're looking at worldwide, everybody would have a variable response to clopidogrel, thus further complicating the picture. So, you know, in a sense, we're saying that we're trying to use what we think is going to be the safest, even though we don't really believe that to be true, that association to be completely true, and at least from a clinical standpoint.
Any other questions? Yes.
Yeah, I have a question. How do PPIs alter the gut flora?
So, mind if I take a stab at that? Mm-hmm. So the thought is that the stomach acid it kills bacteria, right? Minus the few, notably H. pylori, that doesn't really tend to kill. The minute it enters the top part of the small intestine, the duodenum, and it enters the proximal jejunum, that has a bactericidal effect. And when you lower the pH, when you lower the amount of acid secretion, then you potentially increase the survivability of the bacteria that enters your digestive system.
That's theory.
Yeah.
This is not fact. This is logic that's been promoted, but it doesn't, in the end, work out to any clinical significance.
Other questions? If not, I have a question. So when you have somebody that has chronic kidney disease, so when you have one of these observations and you have this person on a PPI, is the discussion different than prior to putting somebody that has none of these diseases and you're starting a PPI? So does that make sense? So you have a person that you start a PPI and say, well, you might develop chronic kidney disease, versus the person that has chronic kidney disease.
Okay.
You have a different discussion.
Yeah. So I think my discussion is still going to be focused on the because in the chronic kidney disease population, there are a few other things that you're looking at, right? There's also the risk of the hypomagnesemia, which we didn't really get a chance to talk about. We do know that in patients with chronic kidney disease, they do run a slightly higher chance of having low magnesium through mechanism that's still not entirely understood. It's not from renal wasting, and it doesn't tend to respond to magnesium replacement either. So in that patient population, I would really review the indications for ongoing PPI use and still use the lowest effective dose that's required to manage whatever it is being used for.
Okay. Well, yeah. I can answer for the two methodologists that put up most of the studies the last 10 years, and their thoughts outright is just to say there are no significant side effects. End of story, at least in regards to these things. So from a clinical point of view, I think you can, including your question, I would just say that wouldn't be a concern for me. If I need a PPI, we use a PPI. If you're worried about the bone, You can worry about them because the patient's female, because they have been on steroids. That's fine. That's another issue. But as far as the PPI, right now, I think our belief is that none of these complications or side effects are significantly increased by a PPI. It doesn't mean that they should be used inappropriately, but that's a motherhood statement for all drugs.
Sorry, and to be very clear, I was really actually thinking about the person whose creatinine is 300 and it's been followed for some time, like a few years, and now there's progression, but you've introduced the PPI, and in that person, and would we say anything, or would the patient say anything? That's kind of where I was going.
Oh, I see. Well, in that case, I would tell them your kidney disease is not due to the PPI. I'm going to start up front, unless they have actually repeated, demonstrated AINs that's actually leading to it. Then you could argue that perhaps the PPI was the one that's causing the AIN. But I would first be just very clear in saying that the kidney disease is, at this point in time, we show no causal relationship. So the kidney disease is not related to PPI. It may be related to underlying cardiovascular disease, diabetes, whatnot. And depending on the indication, which to continue it.
Yes.
I mean, this might be like another topic in itself, but aside from the drug interaction, all these other effects could theoretically be seen with like clinidine or any of the other antacids. I don't know if maybe briefly comment on, is there a body of literature about the other acids for the patient in any of this? Because that might just be one kind of big signal that says all of this.
Because one of them I showed, they do kind of lump even the H2 antagonist. Now you cannot really get the Santac anyways. So, I mean, it's just a degree about acid suppression. So I know some of them really just isolate to PPI, but many of them, especially the osteoporosis one, they actually put in the H2 antagonist. And the odds ratio always a little bit lower than the PPI. But, you know, I guess in population they look at, there's more prevalence they use PPI than the H2 antagonist. So I think for certain drugs, you already kind of lump them together. You also see some effect H2 antagonists, but not as much as the PPI. But at the end, it's still the same. I agree, the same as Dr. Enns. I mean, all of them are just, we want to lay it out there because we got asked a lot by the patients. And I go through with every patient to say, do you really need it? It's something many times they put on the drugs by a family doctor or years ago. No one bothered to ask them. They just keep taking it. No one stopped it. I just asked them, does it bother you having symptom? I mean, basically describe them. So what is like now the Choose Wisely Canada, they kind of like PPI is one of the ones that we wanted de-prescribe. So basically, it doesn't matter which patient, could be the one with chronic kidney disease. It's a list of medication, especially our elderly patient, they're polypharmacy, taking lots of medication. It's definitely one of the ones that I ask them, say, do you really need it? If not, stop it. They may get worse. They may have GI symptoms. Then I'll put them back on again as needed. But I'm not just, it's a question that I'm asking everyone to just stop it if you don't need it. Mm-hmm.
Any other comments or questions? If not, before I thank our presenters, next week's Grand Rounds entitled Fever in the Returning Traveler. So someone from infectious diseases, just so you're aware. Thank you, all three of you.
Thank you.
Doing good? Thank you.
I hope you smushed it up.
Cut it out to about a coin size.
How are you? I'm good. How are you? You're walking normally.
Sort of. For now.
The problem with the overuse of PPI is indication.
And you said you weren't drinking because it was giving you acid because of pregnancy. But you didn't look pregnant then.
Yeah, I look like pregnant. I don't know. I didn't gain that much sleep.
It's amazing amount that I continue to say something different. You did physiology that continues to work. I think I'm a man for it.
Oh, yeah.
You stay home for a couple of days. You know, it's repeated over and over and over.
Oh, yeah. That's the thing. But I'm glad that, like, they were able to not put me in calls, so it's good.
Yes, yeah.
That's the one thing. I don't think I could have done it.
Well, do you want me to take that?
Yes.
Or you can.
Excellent. No, I think it was excellent. I don't have, like, basically.
Yep.
Thank you.
Good.
Thank you so much.
What do you want? What do you want? Black. Black. Love your slides. I don't think I'm doing it now. I know. That's what the other side actually goes down the number.
Your call will be disconnected.